Hi, everyone, and welcome. So good morning, good afternoon, good evening, wherever in the world you are. Thank you so much for joining us. Today, we're going to be talking about transitional care in rheumatic disease and inflammatory bowel disease. My name is Pooja Mehta. I'm a rheumatologist from London, and it's been a huge pleasure of mine to host this series. And today is the last in the series, so let's make it the best. We've navigated through nearly all of rheumatology. So we've talked about rheumatoid arthritis and single cell RNA sequencing, inflammatory myositis. We had a day at the spa, spondyloarthritis. We covered experimental medicine, basic science, translating to clinical medicine, and talked about biases. And today we're going to bridge gastroenterology and rheumatology, pediatric care, as well as adult care, talking about transitional care in inflammatory bowel disease and rheumatic disease. It's a huge pleasure to have two expert speakers from across the continents. In America, from the University of Pennsylvania, we have Professor Alexis Ogdi, who will cover rheumatology. And then from the pediatric gastroenterology side, Dr. Priya Narula from Sheffield Children's Hospital in the UK. So tonight's webinar will last about an hour and a half. Each speaker will have about 30 minutes, and then we'll have a joint panel Q&A. Please do engage. This is your opportunity to ask the experts whatever you've always wanted to ask, or as things may develop and evolve as you hear their talks. Please put your questions in the chat, and then we will ask our speakers your questions in our joint Q&A. So I'm going to stop talking and hand over to our speakers. These are my disclosures. And I'm going to hand over to Professor Alexis Ogdi from the University of Pennsylvania. Thank you so much for joining us.
Thanks so much for the opportunity to be here today, or this evening, depending on where in the world you are. So I'm going to talk specifically about healthcare transition in rheumatology, and as an inflammatory doctor and spondyloarthritis specialist, it's kind of nice to be able to be here with my gastroenterology colleague, because this is like a four-way transitions point of view. So I'll talk mostly about rheumatology transitions from pediatric care to adult care, and how we kind of think about that. And I'll give more examples in SPA and inflammatory arthritis, obviously. We're going to talk a little bit about challenges, gaps, and strategies for better outcomes. These are my disclosures. So what are we going to talk about? What happens during the transition of a care? We'll talk about consequences of suboptimal transitions, and then we'll kind of go through some recommendations for successful transitions. So I'm going to start with an example that's kind of an amalgamation of many of the different patients that have transferred care over the years. But let's say Ben is a 16-year-old freshman in college. So being in a university town, we get a lot of this scenario. So he has a history of juvenile spondyloarthritis, diagnosed at age 16 with sacroiliitis on MRI. He's been doing really pretty well in his current treatment. I won't say just abiologic therapy. And this has been pretty stable over the last couple years. He's been followed at Dr. Angel in pediatric rheumatology, but now that he's in college, Dr. Angel and his family want him to start seeing someone while he's away at college, an adult rheumatologist. And so let's say that's me. And Dr. Angel specifically named because our pediatric colleagues are definitely angels. So in this transition, actually, before I talk a little bit about the specific transitions, this is how it usually goes. So this patient has been cared for in the pediatric rheumatology clinic. In pediatrics, if you're an adult physician, they get a lot of hand-holding over there. So they get a lot of time with the rheumatologist. The rheumatologist is there with talking with the family as well as the patient. Most of the time, the parents are in the room, or a parent is in the room with the child while they're having the conversation, going through the joint exam and what's been going on lately, and then talking about all decisions related to their care. So this student, or the 16-year-old boy, has had someone in the room to help him think through everything. Now he's at college learning to live on his own, and at the same time going through all these different transitions, trying to learn how to take care of himself. So he's starting to learn how to do his injections by himself at school, maybe utilizing the clinic there, or maybe he hasn't quite figured that out yet. And also, then coming to visits on his own is going to be new for him. And sometimes the parents come along. We'll come back to when we talk about challenges for the adult rheumatologist, but it's definitely a big shift in the care paradigm. So, the ideal transitions of care aren't as abrupt. They don't happen just because you move away to college and then you get a new rheumatologist that's of a totally different discipline, adult versus pediatric care. But ideally, they're purposeful, planned movements of adolescents or young adults with chronic physical and medical conditions from child centered to adult oriented healthcare systems. Um, about half of patients with juvenile rheumatic diseases will continue to be monitored for their disease and need to transition to adult care. Of course, the good news is there's half of them that don't, but this is, in other words, very common that kids are going to live with their diseases and transition to an adult provider. And ideally, that has been planned all along the way, and there's been seeds planted about what that's going to feel like so that it's not so abrupt by the time they come to us. This is a really vulnerable time for a few reasons and depends on the circumstances set up to the transition. But if you think about when you're changing from one provider to another, there could be treatment interruption. If the therapy's been prescribed by one provider and now you're transitioning to another, that sometimes requires a new prior authorization. If you're in the United States, we have to go through prior authorizations. And so there can be a lag in the transition of the prescription. Ideally, that prescription is continued from one provider until it's taken over by the other, but inevitably that falls through the cracks sometimes. Uh, Also, it tends to be a rough time in life when you're going from full care or being under the care of your parents to being on your own, and some people do that better than others. And so even just the stress of the whole change can result in a disease flare. And then finally, the loss to follow-up is real. So this is one of the biggest risks with transition is that they don't quite make it to the adult rheumatologist. And so we have to monitor carefully for that. And that's where a nice partnership is helpful. And we'll come back to that in a little bit. So if there's a bad transition, what can happen? Well, number one is decreased medical continuity. So that's exactly what I just described. It might be loss of medications. And we do see this quite a bit in adult rheumatology. It's in the United States, we don't have enough rheumatologists. I think that's true around the world. But getting into an adult rheumatologist is really difficult, especially if you're in the middle of the country toward the coast where there are more rheumatologists. It could be easier, but we're talking 6 to 8 to 12 months to get into an adult rheumatologist. So if you don't have continuity with that pediatric rheumatologist, you may lose coverage of the medications or not, or even lose the prescriptions. Poor medication adherence often happens too. If you aren't at home with mom or dad taking care of the medications and laying them out for you, it's possible you might miss it, especially if your brain is going in all kinds of different directions with the new like college classes, etc. And so medication adherence tends to fall off among adolescents, not all of them, but some of them. There's more disease flares, which makes sense if you have loss of medication continuity or poor medical adherence, then you are more likely to flare. But also, I think, again, that transition can be really stressful. Progression of disease is possible if you have continued joint swelling and you're not getting good control of the disease. You may see progression, like development of deformities if the patient has psoriatic arthritis or rheumatoid arthritis. And we obviously don't want that to happen. And then loss to follow-up is, as I mentioned, is very common. It's hard to get into an adult rheumatologist. It's also hard to navigate the system. So if your appointment is canceled and rescheduled for another year later, which sometimes unfortunately happens to us because the computers just do that when an appointment is canceled, and they give them the next one, which is 6 to 12 months away, the patient may just give up or may not know how to navigate that or may continue waiting for the next appointment. So knowing how to navigate the system in the United States particularly is very frustrating and takes some know-how. And again, long-term risks are suboptimal school and work performance. If you're not feeling good, you're probably not performing optimally at work or school. decreased quality of life, both in the short term, but also the long term if you don't have good care long term. And then limitations on productivity. Again, if you're not able to function well, you're probably not as productive as you could be.